Good afternoon. It's a real treat to be back at this conference. It's probably the most meaningful conference I attend in that it brings together families, providers, basic scientists, all with a common goal. And have been very much looking forward to returning and sharing some of the stories, some of the information around how we care for patients, and some of the ongoing efforts that many of us are involved in at present. I'd like to thank Dr. Malkin, I'd like Li-Fraumeni and the organizing crew, and as well as the team back in New York who cares for individuals that come to us with P53 mutations and Li-Fraumeni syndrome. Dr. Offit leads our group. I'm highlighting 4 of our genetic counselors. 3 of them are running around here. Kelsey Breen, Jennifer Kennedy, and Elise Fiala, who are instrumental in caring for the patients that we take care of with mutations in P53 and other cancer predisposition syndromes. So today what I'd like to do is, and I know some of this will be redundant, but I'd like to provide a little bit of background around genetics. And listening to some of the conversations, I think that we can never get too much genetics or too much education. We throw a lot of information at people, particularly in our sessions, and expect them to understand a 900-level genetics course very quickly, and then have a delivery of other information around care. So just a very short background on some genetic principles, some illustrative genotype, phenotype stories that our clinic has been a part of. Move on to describe the pediatric translational medicine effort at Memorial-Sloan-Kettering and illustrate a patient who has a mutation in P53 and how they've been cared for as part of this translational medicine program, and then to finally end on some additional efforts. So, as promised, in terms of background in genetics, one can't go far without talking about Gregor Mendel in genetics, who is a botanist who lived over 150 years ago, who laid out the principles for us about autosomal dominant and recessive disease. And through his work with pea pods and describing plants, we have an understanding of how traits are passed on and how many copies are necessary for a trait to express itself. So in the nucleus of all of our cells live our chromosomes, and on our chromosomes live our genes. And for TP53, it lives on chromosome 17, and we have 2 copies, one from mom and one from dad. And this is a beautiful karyotype. It's mine. I did as a genetics fellow, and I think I have 2 copies of P53. So in Li-Fraumeni syndrome, we tend to think about this as an autosomal dominant condition, and we're continuing to learn more about Li-Fraumeni syndrome and the genetics of it. But for classical understanding, it's an autosomal dominant condition, meaning that if a parent has a mutation in the gene, there's a 50% chance that their child will also have the condition. And there are 4 scenarios that can unfold themselves as the genetics pass down from mom and dad. So this is a pedigree of a autosomal dominant typical Li-Fraumeni family as we learn about it in medical school, but this is changing quite a bit. And as I think you'll see through many of the stories, we're learning more and more about the genetics, and it's not as straightforward as we originally thought. So some terms that have been thrown around a lot have been constitutional, wild type, normal, abnormal. And when we're talking about a situation where a mutation is not present, we say we're talking about wild type and normal, or constitutional normal, wild type normal. When we're talking about a mutation being present, we may say a constitutional mutation or a germline mutation. So there's been a lot of interchange of those terms as I've been sitting here. And just to reiterate what they actually mean, this is a little bit more of, to hammer that home. What I've illustrated, and I'll come back to this illustration, is this body, which doesn't appear to have any changes. So we'll call that normal or wild type. And this darkened, highlighted schematic we'll call an individual that has a germline mutation as we know it in a 50% ratio. So in terms of the families and stories that and patients that we take care of, while many of the family histories look classical, we continue to learn a lot about them. And I always start any talk I'm talking about related to P53 with this pedigree in particular, as while it looks like and it is, an autosomal dominant Li-Fraumeni family, and we've known about the leukemia association for quite some time. This was the first family that was reported in the literature of a boy with hypodiploid leukemia, which Kim Nichols spoke about earlier today. And this was a family I took care of as a hem-onc fellow. And what we learned from this family was that subtype of leukemia should make us think about LFS and P53 mutations. One of the questions that came up earlier today was, can you have P53 mutations and a BRCA mutation? And how common is this for people to be walking around with more than one mutation in these cancer predisposition genes? For the highly penetrant mutations, it's pretty rare, based off of the data we have from our clinic. But it does happen, and we're in New York, and our clinic is in an area enriched for founder mutations in the BRCA gene. And we do care for patients in our clinic that have both P53 and BRCA mutations. This is a patient we care for that came to us without a diagnosis. We performed testing because of family history, and she was found to have a mutation in P53 and BRCA, both of which are pathogenic. With this information, she chose to undergo a risk reductive surgery. And at the time of the risk reductive surgery, on review of the pathology, she did have ductal carcinoma in situ and breast cancer. This has been tested in other family members, and it would take quite a few slides to go through in its entirety, but it's just to illustrate that you can have a mutation in one of the more highly penetrant cancer predisposition genes. So as was mentioned earlier about the Brazilian population, there is a founder mutation in this group, and this is just to illustrate that there are some Brazilians that have migrated to New York, and we see them in our clinic too. And we have seen a child with the typical cancer type that's associated with this mutation, the adrenocortical carcinoma. So those are some typical autosomal dominant pedigrees that we tend to see, but from each of those, we continue to learn more, and there are stories with every case that we see. But there's more. So as I mentioned earlier, the arrow right now is pointing to what's considered wild type or normal. The arrow now is pointing to what we consider constitutional germline, someone with a constitutional germline mutation. And now we're understanding that we have a lot more than that as we've been doing increased tumor normal sequencing. And one of the terms mosaic that has been thrown around today can refer to a situation where someone is germline mosaic, where they just have a mutation in their reproductive cells, or they're mosaic perhaps in some of their skin cells, their reproductive cells, and other tissue compartments. In each of these instances, you don't expect to see their parents with the mutation, but from this point on, the mutation can be passed down. Dr. Weitzel and others have been speaking about clonal hematopoiesis, and just to make the point about that, this is something we're picking up in the blood, but we don't tend to pick it up in other tissues unless those tissues have been infiltrated by hematopoietic cells. So this is a pedigree in a family that we care for, where we first were taking care of one child with a history of neuroblastoma. And in going through the family history, we learned of a brother, and that wasn't initially obvious to us or based on the initial go-around that the oncology team had done for the family history. And we then we tested, so through the patient that we were caring for, his tumor normal sequencing revealed a P53 mutation, and we were in a position where then we were trying to segregate or check for other individuals in this family with a mutation in this gene. And we tested mom and dad, and we didn't detect it in either mom or dad. And then we learned about the brother, who also had neuroblastoma, and we tracked down his tumor tissue and found that he had the same P53 mutation as his brother and in his tumor. So we then went on to test the siblings, and his sister also carries this mutation, and we were left wondering, why did we not pick up the mutation in the parents. So in genetics, this results from one of a few reasons. One, mom isn't mom or dad isn't dad. And both of those situations can occur, albeit that dad being dad is probably more common. But in this instance, in addition to having LFS, they had apple syndrome, meaning they didn't fall far from the tree and they looked very much like their parents. And we figured that out through some additional genetic testing. But we then went and we tested mom and dad. We did skin biopsies, buccal swabs, and deep sequencing off the blood on a couple of occasions, and we still didn't find the mutation, suggesting that this is probably a gonadal mosaic story. And we're in the process of doing a little bit more of a workup on the parents, dad specifically. So this is this is a different type of inheritance just to be aware of in clinic. This is a typical Denovo family that we might see where we detect a mutation in one individual and we don't pick it up in mom or dad or the siblings. But again, there's always the possibility that one of the parents is gonadal mosaic. This is a family pedigree or a pedigree of a family that we take care of that on initial inspection is relatively classic for LFS, and that the child has a brain tumor and dad had a cancer at a young age, and there were additional cancers at young ages on the father's side. But what this story told us it was to take a better medical history and to try to learn everything you can, because in this instance, as we went through the history, mom said, by the way, my son was conceived by in vitro fertilization, and we had stored some additional embryos and then donated those embryos to the fertility clinic. So, and all in good faith. And it was much later that the diagnosis in the family was made. So now whenever we're seeing someone, we go through very detailed histories and we're more cognizant about fertility practices and potential ways that patients may be presenting to our clinic. This is a scenario. A couple of weeks ago, a colleague had passed on an interaction they had with a patient that had tumor normal sequencing done, and they said, my Aunt Susie had her tumor and blood sequence, and there was something in her blood, but not really. And that's it speaks kind of to how we understand this at the moment. We've come a long way. We're continuing to learn more, and we'll through a lot of the work of Dr. Weitzel and others get there faster in terms of understanding what the difference is between clonal hematopoiesis and mosaicism, and what the tests are that are necessary to really differentiate. So those are some stories of patients that we care for, and I would like to move on now to some of the efforts going on in our clinic on the oncology front and genetics front with our pediatric group. So for our pediatric oncology team, we have a pediatric translational medicine program, and for patients that present to us, they of course have a detailed history and physical, undergo molecular testing of both their germline and their tumor. And if possible at the time of surgery, the tumor is taken and implanted into an animal to establish a xenograft. There are some initial diagnostics that are done as necessary to direct treatment. We have a weekly molecular tumor board where we go through all of the information that has been generated for our patients as part of their evaluation, and determine if we want to do more expanded testing and genomics. We review all of the sequencing data that's been generated to that point. Xenograft information, if it's available, meaning is there anything that we've learned about the animal that we've implanted and has it taken, meaning is the tumor growing in that animal. We do additional methylation testing for our patients and then go through how our patients are responding. So this is, typical mouse, or I understand there's a fair bit of talk about zebrafish. We use mice for our model system and looking at mutations. And we hope that as part of this, we are able to translate this to clinical practice. And we do have a nice set of examples right now where we have used the molecular information. But in the context of for our patients with heritable predispositions contributing to their cancers, we do this as well. So this is an instance of a patient, an individual that we care for, that I think has really benefited from the 4 boxes of genetics. And the 4 boxes are how it can help us understand a diagnosis, how it relates to how the information might be of benefit for screening and risk reduction, therapeutics, and then family planning. And all of those things aren't necessarily of benefit to someone depending on when they're coming to us, but we hope that that some of them will be. So this is an individual who unfortunately had lost a family member to a sarcoma and another cancer, and had decided to undergo testing, which we performed, and the results revealed that she too was a carrier and had a mutation in P53. And on the first surveillance scan we picked up a high-grade spindle cell sarcoma in the breast, and she fortunately was detected at a point where this was less than 5 centimeters. Now, for these diagnoses, this gets into the therapeutics part. Well, we don't necessarily have therapeutics that we're armed and ready with for P53 mutation carriers. This does come into consideration when there are branches in thinking about therapy. So in our field right now, in caring for patients with sarcomas, there are beliefs that you should treat with chemo and radiation in this instance, and then which some people do, and then others, when it's less than 5 centimeters, feel as though surgical resection is adequate, and the data supports that. So in this instance, by detecting it early and being less than 5 centimeters, it was a situation where, knowing the person's constitutional makeup, it was a bit of a no-brainer in terms of whether or not we were going to throw radiation and chemotherapy into the equation. And we're a year and a half later, we continue to be involved in the patient's care, and I'm happy to say she's doing very well. This, in terms of family planning and risk reduction, this is also an example of where the information was used for pre-implantation genetic diagnosis for a sibling. So it's a very nice illustration of how what has been tragic in one generation has been informative for the next, and being put to the use that we hope that the information can be. Now, just moving to some data. These are the tumor types occurring in MSK patients where we've identified mutations. We have a bit of a bias for breast cancer in New York, but as has been illustrated by other presenters today, there's a broad distribution of cancer types, and in some instances, whether or not these are true and unrelated, we're still figuring out. This is an illustration of where the mutations occur, and these are pathogenic mutations for the patients that we care for. Not illustrated here are variants of uncertain significance, but we have a broad range of mutations that have been detected in our patients. In our pediatric effort and in doing agnostic germline testing, we've picked up P53 mutations in the first couple hundred patients that we've sequenced in the settings of a child with a brain tumor, 2 with osteosarcoma, 1 with osteosarcoma and Ewing sarcoma, and then 1 with a history of, who is part of our pediatric service, but an adult with a breast and a Ewing sarcoma. So as the field has recognized in many ways caught up with what Dr. Malkin and others were thinking about since 2004, and probably before that, was that we should be screening and following patients that are predisposed in pediatrics. And as a result of many of the pediatric sequencing studies, we now have guidelines and recommendations for patients that we identify as being predisposed. So in New York, this is our screening clinic on the pediatric front. And what's nice to see is by identifying the probands, we're identifying other people in the family that can also avail of the screening recommendations that we have. In terms of understanding the variants of uncertain significance in the gene, I just want to highlight a couple in P53 and other genes. I want to highlight a couple of efforts. One is a multi-center effort between our Boston, Dana-Farber, Dr. Garber's leading from up there, ourselves, Dr. Offit, Mark Robson, Susan Domchek from Penn, and then Fergus Couch from Mayo, in an attempt to capture genetic testing results from laboratories revealing variants of uncertain significance, and through the metadata trying to make more sense of what all of these things mean. And then the last effort I want to highlight is run by Sharon Plon, who spoke earlier today with ClinGen. In addition to the P53 gene domain working group, Dr. Plon and I are working on trying to take better advantage of the somatic data that we're generating from tumors and how it might help us in classify germline variants. So that's all. And